be a candidate for placement of plastic stents if you choose to, because there's good adherence here, and so you can use the standard Seldinger technique. Now, in our practice, we've transferred over to using lambs for all of these fluid collections. Part of the reason for that is just it's so much faster, easier, and it really gives us the ability to use the lambs as a port to enter into the cavity inspected. And especially if we think this is infected, and I don't know, we'll see, then it's important that you get good drainage afterwards. So in terms of the size of the lambs, you could use a 10 or a 15. I'm just going to go ahead and use a 15 here because my experience has been, even though you don't need a larger lambs, if there's some necroses or necroses form, it's going to be easier for that necroses to drain through a larger diameter. So I just always use a 15 now. I don't use a 10. Now you do have to you have to modify your technique a little bit and be more careful if you use a larger lambs for a smaller collection like this. So I'll show you that. But firstly, hopefully you can see me inserting the delivery sheath, which has a hydrophilic coating. So all you need to do is wetten that coating and it allows it to slide very easily.
This next part, the diameters you were, the numbers you were referring to were the diameter. I believe now there's also 2 saddle lengths available, a 10 and a 15. How do you choose which one to
length? That's correct. So, generally, I rarely use the 15 saddle length because if it's already that separate from the wall, I just have some other concerns that need to be addressed, but usually the 10 millimeter saddle length is sufficient. Now, in this case, you can certainly measure out the distance here if you're not sure. So you'll see this is only 4 millimeters. And the other thing I should actually emphasize is that you always switch on your Doppler. You should make that sort of a routine habit to always check the wall for interposing. And when you do that, you need to release your transducer so you're not compressing the wall with your transducer. So with the up-down wheel, just sort of release that pressure against the wall to see if there are any interposed vessels and just scan around. So remember, when the flange opens up, and this is going to open up to a diameter of almost 3 centimeters, right? Then you don't want to have that flange close to a vessel if possible. All right, so I'm going to turn the Doppler off now, and we will proceed to advance the sheath out. And what's very important is that you not push this sheath against resistance, because then you can start to partially deploy. And when you're angulated, that's when you may get more resistance. So now you can see the sheath coming out. It's very echogenic. It's right up here. And Courtney, my nurse, just told me that I'm hot. I like that. So that means cautery was just applied. She's going to disconnect that immediately after I'm in. But I'm in a good position now. I can see the sheath linear. And if you're beginning, then it's always smart to just measure out the distance between the tip of your sheath here and the opposite wall. See, now that's 2.4 centimeters. So you just want to have some estimate of how far in your stroke length is going to be. All right, so I think we're ready to go. And so what I'm doing now is I'm just the sheath forward, like an FNA needle, and I'm just advancing that sheath forward, and I'm stepping on pure cutting current to go in. And I'm in. Now, once you're in, you get some bubbles from the diathermy. Courtney just disconnected immediately so that I don't end up burning through the opposite wall. You don't want to accidentally do that. And I'm just going to press this all the way against the opposite wall now, but I don't want to start displacing the cyst away from the gastric wall. If it's not fully adherent, that can occur. Now I am going to lock the sheath. All right, and now I'm going to take off the safety here. That's the yellow safety. There's a gray hub
Do you have a rule of thumb to ensure that you have enough catheter in? Or do you adjust as you go along?
I'm going to adjust as I'm deploying this. Just do it slowly, that's all. Just make sure you do it slowly.
There you're
Slowly,
pushing
slowly.
the catheter forward a little.
Coming now, right? There it is. Now it's fully deployed. It's a nice big disc, right? Now you want to snug this up against the wall of the cyst like this, like that. So I won't deny this is a relatively big lambs for for the size of the cyst. But as I said, I want to get excellent drainage afterwards. It's really about the risk of the lambs getting occluded with some debris and necroses or even food afterwards. All right, so now I'm in great position and I'm going to deploy the proximal flange inside the working channel of the echo endoscope. So now I'm locking again, right? So that the sheath doesn't accidentally jump forward or anything like that. And now I'm pulling back the gray hub. I heard an audible click, right? So that means that the distal flange is fully deployed. Now I'm just deploying the proximal flange and it's fully deployed now. Now I'm going to switch to the endoscopic view. So let's get the endoscopic view up. And all I do now is under endoscopic guidance, give some gas, it is CO2, and push the proximal flange out of the working channel. And there it comes. And it is now deployed. See? Now that's fluid. And it doesn't actually look purulent. So, maybe this isn't the source of his fever. We maybe have to check further. But we'll definitely get some of this fluid and send it gram stain and culture sensitivity. But I have to say, I'm not that impressed with the fluid. It's not looking very purulent at all. So now, the next point is when you pull this out, this is the cable. You've already deployed the stent, but at the tip, you have that bougie-shaped ceramic tip. And that thing will, barely fit through the saddle lumen. So you need to pull back slowly. You may even see the micro wires that run along the side and converge at the very tip of the ceramic bougie tip. All right, so I'm pulling this out, and now I'm going to dilate the tract, and I'm going to use a CRE balloon, and I'm going to dilate up to the diameter of the lambs, which is 15. So the CRE balloon is going in. Now you could do this through a gastroscope, of course, but I find that great position. I have great visualization. I have an elevator that I could use. So I find it easiest just to use the echo endoscope to do this. Now, if you ever have difficulty, you can always advance the wire out first, but otherwise I'll just target that lumen. You want to make sure, of course, that you're not going in the interstices there, but here it goes very easily in, and you don't want to push too far, especially with a smaller lesion like the gallbladder. You want to be careful there, a non-adherent structure, that you don't push the gallbladder off of the lambs, the distal flange. So I'm in far enough. Start to dilate up. We'll go up to 12 first, right? It's 12 to 15, so we'll go up in stages. And the nurse would just tell me, and now I can push it out like this. Make sure that it's in the axis, right? And you can see it inflating, right? And so I'm at 12. There's a little fight, so we just wait till that fight's gone. All right, now go up to the next level. Now, when you dilate up to 15, it's not really going to be 15. And in those cases where I really need to get optimal drainage, I might even go a little higher. So I'll pick a 15 to 18, but this is fine for now. All right, and now go to 15. So that'll be the full. So it's all under direct visualization, good position. And when it's up, I deflate, go down, and then we're gonna look again and pull out very slowly. Everything can always stay, this is like ERCP, right? You see in the axis of the bile duct. all of these skills are transferable. So now I'm coming out, and now you can start to see inside of this. But now I'm going to switch out quickly for a gastroscope. Right. So there's our.
Ken, can you hear me?
Yeah, I can hear you. Yes.
Hey, Ken, this is Ale. So we are running a little bit late, so I don't want to give you pressure, but can you tell us you have another case?
I do have another case. Let me just give me 2 seconds to look in. Yeah, I've got a case of, I've had a lot of cases this morning, Ali, but this one is a patient with multiple polyps, large ones. And as soon as I just look in for one moment and suck out a little bit, I'm going to run quickly over to the other room. And
can you tell us what will be next case?
Pardon me?
What will be the next case?
Yes, this is a patient. He is 78, and he has multiple polyps found on screening colonoscopy in the ascending colon and the sigmoid colon.
So I can assume everything will be underwater.
Oh, yes, of course. And
Good.
so let's put CO2 on, please. So we only use CO2 now in our unit. Okay, so I'm just going to show you how you inside like this. And we always go in and inspect the inside of the cyst just to make sure. And it's unlikely, but you can be fooled. It could be a neoplastic cyst, and it looks good. And it's because I want to irrigate with some water. Where's the water pedal? Here it is. So you can see here with the water, you don't want to infuse gas too aggressively in here. So you can do underwater cystoscopy and just to whet your appetite for the next case. But everything looks good. So I'm going to pull out now. Everything looks good. I can see that we're not seeing any pus, minimal debris. So, and I'm going to go to the other room, and I'll see you in a couple minutes again.
Okay, we have an infomercial to show, and we will see in a couple of minutes. So Thomas, if we can send live the next infomercial, please.
This patient had undergone both percutaneous drainage and LAMS drainage for a WAN and is readmitted with sepsis. The LAMS is occluded with necroses. There's pus draining. We insert the endorotor through the working channel. You can see the 4 millimeter window at the tip. For necrosectomy, we use high cutter speed, high flow rate, and high suction. This is a all-in-one device. We can suck, cut, and clear without having to remove the endorotor from the cavity. This is called powered debridement, which means there is really very little effort on the part of the endoscopist. We are basically dipping the tip of the endorotor into the necroses and very gently rotating the outer catheter. This rotates the window to the desired orientation. We try to keep the tip at the edge of the necroses, essentially working the tip like a wood chipper. So we are gently swinging back and forth, riding the edge of the necroses. Here you can see nicely illustrated how rotating the outer cannula rotates the window at the tip. You can dig the tip more deeply into the necroses. What we look for is the necroses spinning around, indicating that it is being suctioned in. Here you can see a large amount of pus after we have opened up a pocket of necroses. So we have nearly completely evacuated the necroses. There's a small amount of residual, and here you see the percutaneous drains in place.
So Amrita, I have a question. I was fascinated by this interscope procedure with a lot of debris in the pseudocyst and speeding up. What is your experience with this endoscope device?
Yeah, so I think it works very effectively. It does take some time. It's a little bit tedious because you sort of are keeping the scope in place as opposed to other necrosectomy techniques where you have to go in, gather the necrosis, and then pull the scope out in order to actually debride and remove tissue. And I think what happens sometimes with other devices is that you can get a good amount of tissue, but by the time it's so attached due to the consistency of the material that by the time you actually come out of the cavity, you have very little material. So the time saved in actually being able to stay in place and physically debride that tissue in place, and the suction capability is extremely strong, and the ability to irrigate.
So you suggest to have a therapeutic scope also to improve suction? What you do?
Yeah, so the current catheter requires a therapeutic channel scope. You can use either a single channel or a double channel. The double channel would allow you to have a little bit better suction, but the suction is actually within the catheter itself. So it's really sucking up the material that gets sort of cut.
So the concept is a blade, a rotating blade. So whatever is the contents, it can be used, no?
Yes. Yeah. The other indication for the device is for resection of mucosal neoplastic lesions. So it's the same.
Especially
concept.
fibrotic, no?
Very fibrotic is a great indication. So it really can cut the material and immediately capture it so you don't lose any of the pathology and you're able to both resect and evaluate. Yeah.
So in general, it requires a lot of skill. You have a learning curve for using this endoscope device. Can you tell us?
No, I don't really think too much of a learning curve. It's a lot of painting, similar to if you're used to.
So you need to be
APC.
patient.
Patience, yes.
Take your time, relax there, and let the device making its work, no?
Yes, exactly.
Okay, good. So I don't know if Ken is ready. I don't see Ken. No, probably Ken is on. Ken, you on?
Yes. Yes, good. Can you hear me?
Yeah, you're doing colonoscopy already? Okay, good.
Yeah, so I've just inserted the adult colonoscope HD with near focus capability. And I'm using the water exchange method. It's actually saline exchange because we're using saline. And the gas is turned off. So I'm doing the whole colonoscopy underwater now. And the key when you're doing this underwater, you want to use the infusion of water, which I control with the foot pedal, to distend the lumen just enough so that you can see where to go. That's all. So you are trying to avoid over distension. You can see already there's a polyp here. This looks like more of a semi-pedunculated one. So you know what? Just because of time, I can show you how we do that. Give me a 20 millimeter snare. So normally I'll take all of these out on my way out. But because of time, I don't know how much time I have. I'll take this one out.
And this will be underwater single piece cold?
I'm sorry?
This will be underwater single piece cold resection?
Cold. I don't want to do cold. The reason
you don't like cold? It looks like a small spot.
That are maybe 5 millimeters or so. 20 would be fine. I think 20 will work, or 25 maybe. Let's see. Because there's actually 2 lobulations. Let's take the near focus off here. Let's see if the 20 works. Even a smaller snare will sometimes get the entire lesion on block. In this case, it's also semi-pedunculated, right? But it contracts the lumen. If it contracts, and you can float the lesion up into the snare. So you have it at 6 o'clock, first of all, good position. And let's open up the snare now. The other thing is, it looks like this may have even bled in the past, right? So looks like the 20 is a good size. So the idea is under vision like this, and I'm going to have the assistant just hold this a little clockwise. And now I'll go back into the near focus. See, the near focus lets me see. Now the key is to go do to and fro like this. That helps displace the lesion higher up into the snare, fully into the snare. Plus, you can see where the margins are very nicely. So there are two maneuvers. One is to and fro, and the other is torque and crimp. So torquing is this, back and forth, torquing. So both of those, and the final maneuver is gentle suction. All right. So
and we don't need any injection, no?
The suction is, with water suction, it's a very gentle, gradual suction in contrast to gas where it just reds out on you, right? So slowly close, please. Okay. And once it's closed, I give it the water to look and pull it away and see if I got the whole lesion. And you see it tense away very nicely. And you don't have to worry. You're not going to capture the muscularis propria because it stays round on the outside. It doesn't follow the involutions of the mucosa and submucosa. So now we're ready. Now, because there are probably some vessels in here, and because this is not a large surface area, I'm going to use coagulation current for this. And I'm telling Courtney, my nurse, not to just transect this right through right away. A very slow transection. And we have the heat sink effect as well, which is transferring the thermal cautery to the water, right? So it's minimizing damage both to the specimen and the wall. All right, so now coag, it turns white, right? And now it's through and there's no bleeding. Then I use the tip of the snare to kind of move this around like this. Take the near focus off because I'm a distance. And then put the near focus on to look more closely. And with what? Take it out. And I can look at the margins and see if they look clean. They look fine. So you could put a clip on here and close it if you want. This is in the SM2 layer. This is the second layer of the submucosa, and you're well above the muscle. So, you know, the layer of resection when you do underwater is different from conventional saline assist or injection assist EMR. All right, now let me just continue now.
So
Okay,
the water has basically allowed you to not have to do any injection. It's creating the same effect, correct?
That's right. But you know, everyone emphasizes the submucosal injection. Now, I won't deny that I have always had an issue with the theoretical possibility of tumor seeding, of dysplastic cells when you inject through a lesion. You know, I'm cognizant of that when I do FNA as well. But it's less about the submucosal injection for me. It's about the en bloc resection. I want to get these lesions out en bloc. So I use a snare size that will allow me to get it out en bloc. And that's the rationale for going underwater for me, because the lesion contracts and that allows me to capture a larger surface area. Right now,
we have time for one question. We have time for last question from Amrita.
Yeah, so you've done have done a lot of work underwater, whether it be polypectomy, POEMs. Do you have to change your settings? Do you have special settings for underwater work, or are they the same settings for a standard polypectomy?
They are not.
You should show your generator.
Absolutely have to use different settings when you're underwater. So, and underwater, I'm using usually pure cutting current. And, but when I want to coagulate vessels, I have to use force coag with high wattage. Yeah, so the settings are different.
Great.
And the other is saline. I use always saline. And by using saline, I get excellent thermal transmission, diathermic transmission, I should say. Any other question?
No, that's been a fantastic demonstration. Thanks for your time. Thanks for being patient and waiting for us. So enjoy your underwater day, as always. Hope
Thank
to
you.
see you
Yes,
soon in
we got our
person. Okay, are you coming to Côte d'Azur on vacation in 1 month?
I hope I'm allowed to. I miss so much. Yes.
Okay, just in case you come nearby, just drop a call. Okay.
Thank you so much, Ali.
Ciao,
Good to
Ken.
see you.
Thank you.
Rita, good to
Bye-bye.
see you as well.
So I think it's now time to move to another city.
Urbe wants to power your performance with a promising technique for submucosal dissection in ESD and POEM. Hybrid knife, together with the Vio 3 Precise mode. The Precise mode is provided by the Vio 3 workstation. Fully equipped, it is composed of the Vio 3, APC3, and UrbeJet 2, and serves as the technology platform for standard and advanced endoscopy applications. Urbe's hybrid technology instruments and the FI-APC probes are established instruments in flexible endoscopy. Let us focus on the hybrid knife, which combines high-pressure water jet and electric current for all working steps during ESD and POEM. Especially dissecting the submucosa and coagulating vessels in this tissue layer are important steps for which the hybrid knife is ideally suited. The Precise mode, with its dynamic adjustment of the current curve, offers precise submucosal dissection and pronounced hemostasis with little thermal spread. Depending on the contact surface between tissue and electrode tip, Vio 3 pronounces either dissective or coagulative properties. Broad contact causes a rather coagulative effect. Only contact at the tip produces the dissective effect. Dr. Bina demonstrates the use of the Precise mode for submucosal dissection in a step-by-step video tutorial. Watch it on medical-videos.com. The clinical benefits of the Precise have already convinced many physicians. Dr. Honggang Yu states that Precise extends the utility of ESD knives. Follow his POEM procedure on medical-videos.com. In Professor Chacha's experience, Precise is a huge improvement, which leads to fewer uses of the coag grasper. According to Dr. Elkoli's opinion, conventional coagulation modes are not satisfactory, as the carbonization contributes to loss of orientation. She thinks that Precise is a genius solution, as it preserves the orientation. Visit us on medical-video.com to learn how to dissect or coagulate vessels using the Vio 3 Precise settings with the hybrid knife.
So we still have our orientation and go into the grande finale. Actually, this is a bridge between New York and Guayaquil in Ecuador. And I welcome Reem Sharaiha from New York. Hi, Reem, thanks for waiting for us.
Thank you for having me.
We have been waiting for you, so I hand over to you for the final moderation for the final two cases. Thank you.
Great. So we are going to be seeing Dr. Carlos Robles from Colombia doing two cases, one on endovascular therapy and the other on EUS ablation.
So, hello.
Hi, how are you? Welcome.
Thank you so much. I'm from Ecuador, not Colombia.
Oh my God, sorry. Sorry.
It's okay, no worry. So, thank you
Colombia on
so
the
much
mind.
to Thomas and Alessandro and all the team for inviting us. So, we have this interesting case today. I don't know if you are looking for the big vessel that we have. It's a gastric
Yeah,
varice
we
that
can see your
just bleeding
endoscopic
recently.
view.
So we can run the video. So this is a big vessel. So this the video was taken today, just to show you faster. And now I can show you the US view. ¿Puedes cambiar a endoscopía, por favor? So what I do always when I will do a treatment by US is to see the vessel. And you can see I am in the gastric area now, and I put water just to see very well my vessels. So the traditional technique is going inside and going here, but the problem is that we have big vessels inside.
Yeah.
And one of the advantages of US is that we can follow the vessels. And this is what I do when I do this kind of treatment. So now I am following the vessel, and you can see this is the feeder vessel. So I am at the level of the esophagus now, and I will go going inside here, because you can do it also going inside the gastric varice. But if you do a modified technique that we'll do here, going inside the feeder vessel, you have some advantage that are using less coil first. So now I am inside.
And any
Second, I can
technique
do a
you use to find the feeder
varicellography.
vessels?
Wait. Espera. So now I am inside. You can see here. And I also confirm, puedes retirar. Doing an aspiration, as you can see here. So I know that I am inside the vessel. And I do a flush first with saline. And then I do varicellography using contrast, just to confirm where I am, and just to see if there is any shunt or any problem, and I don't see nothing. So I come back to US image, please. So now I will use the coils first, and we do a recently publication coil. Necesito un coil de 18, está bien. So we do recently a publication regarding the use of coils, and randomized study showed that that the combination therapy that was developed by my great friend Dr. Binmoeller is superior to the technique of coil alone or glue alone. In this case, to glue alone. But if in cases, if I see, dame uno de 20, por favor. If I see a shunt, I will use just coil.
Okay.
The problem with coil alone is that you need to use more coils. And the second problem is that you have to use, you have patients, the 40% of patients that recover the gastric varices after 3 years of follow-up. So it is necessary to do a second or third treatment when you compare with the combination therapy. So today I will do the combination therapy. I am putting and applying the coils. You can see here.
Both, yeah, fluoroscopically and endoscopically, I guess.
So this is a big vessel. It's more bigger than we see. So I am using larger coils, and I am using a standard spec needle from Boston Scientific 19-gauge needle.
And do you pre-flush the needle with anything, or just because you're aspirating then injecting with dye, you don't need to do anything beforehand with the needle?
Can you repeat the question? Sorry.
Do you prepare the needle with any flush before you go in, or because you're already aspirating when you find the vessel, you don't need to do any pre-flush with saline or anything like that?
This is a good question. I always flush with saline solution.
Okay. And
so
with
this
the
patient
coils,
will need more coils.
Yeah, it looks like a large vessel. I was going to say, do you use the larger coils first until you see obliteration and then add the glue, or what's your technique for how many coils you use?
Oh, how many coils? That's a very good question. So I need to see at least by US that there is an obliteration. You can use 2 coils or 3 coils to do a less expensive technique. But I don't believe that is very secure. In my experience, I use more coils, and then I use the glue, because I need to see if there is not flow, at least, or the diminish of the flow at Doppler, as I am showing you.
Yeah.
Otro más.
And you should have very nice.
This is a big vessel.
Yeah, you should have very nice way of finding.
And I am in the feeder vessel.
Can you talk a little bit about your technique of finding the feeder vessels? Do you sort of follow the big vessel that you saw in the esophageal area to see where it sort of goes to? Or what's the best technique
Yes.
used? I think that's probably one of the hardest things when you start doing these techniques.
Yes. The thing is, you need to go to the stomach, put water to see very well that you are in the gastric varice. Otro más. And then, when you are there, you just follow the vessels until the esophagus.
Okay.
And then you will find, because the feeder vessel, because all the vessels finish in one. It's in rare occasions or rare situations that you have more than one feeder vessel. But it's, you can see also when you are following the vessels from the stomach to the esophagus. Okay, now I think I need one more. So you see very well now at the US. Otro más. You see very well now at US that we have the coil inside.
And just sort of a basic question: do you have your patient under general anesthesia or moderate sedation? Here in the U.S., we always do it under general, but I feel
I do under general anesthesia, First, because it's a therapeutic. It's better that the patient be in very good condition and don't move. Uno más. Y Salina. Uno de 16, por favor. And you need to remember that sometimes these patients could bleed during the procedure, so it's better to have very good control of the respiratory area.
Agree. Agree.
Okay.
What about
So I
antibiotics?
am just finishing my last coil, and then I will pass the glue. So we have 160 patients treated by this technique, and we didn't have any until now any embolies for the moment. Regarding the series of Kenneth, who have 3 cases.
But who's counting?
Okay, now this is what? Sorry. So I do a flush before to pass the glue. So I'm ready to pass the glue now because I see very well the coils inside by US. So I will pass the glue.
And what type of glue are you using? Because maybe the embolization can occur. Oh, we see the nice, we see the glue and we see the obliteration of the vessel now very nicely.
Yeah, and then I flush with saline. So you see here.
It's beautiful.
So now it's a complete obliterate. And I finish. So very good. I will pass just my endoscope to see the gastric varices. But you can see also by Doppler.
Yeah, no, that's really, really nicely done. When will you bring the patient back?
Okay, normally in our protocol, 4 weeks after the treatment, the patients come just for an upper GI. And then 1 year after. Necesito la imagen endoscópica.
So we see it now fluoroscopically, very nice.
Yeah. Imagen endoscópica, por favor.
We cannot see the endoscopic.
Now I will do an aspiration now. An insufflation. La imagen endoscópica, por favor.
So do you give the patient antibiotics?
Yes. Always prophylaxis, just to avoid any. Tenemos la GoPro, podemos usar la GoPro.
Perfect. We see the
So
endoscopic.
I will. You see here now.
Yeah.
So the gastric varices. The difference is that when you put it in the feeder vessel, the gastric varices disappear. Doesn't become hard because the obstruction is behind. You see?
Yeah. Yeah, yeah, yeah.
At least 80% of the gastric varices is disappearing.
And it will continue to disappear as the weeks go on. It's very sort of a gratifying procedure.
Yeah. In few days, there will be no more gastric varices. So I finish here. I believe that this is perfect. And I will change the room now for my last case and the last case of today.
Okay, great. So while you're changing the room, I'll just recap on a couple of things you've said. So patient is usually under general anesthesia for these kinds of procedures. We give prophylactic antibiotics. And the use of a 19 gauge needle, because that's what you can pass the coils through. The coils that we use in the US are the Wilson Cook coils. I believe it's probably similar in Ecuador, not Colombia. And usually you try and find the feeder vessels, which I think is probably sort of the hardest part of the initial EUS. Obviously, if you can't find that, you go to what you see, and that's important. And then you use coils, as many as you can. Start with the longest one in length. They go from 20, 14, and then to the short ones like 5 and 7 centimeters. And here we saw that he used probably 7 or 8, and it was done very smoothly. Other things that you notice that he made look very easy is that the EUS and the needle was always in full view. And that's really important when you do any type of access therapy into blood vessels, into bile ducts, or anything like that. And then finally, he used glue for sort of a completion. And the theory behind glue is that you use it's a scaffold for the coils. Don't know if anyone's trying to come on yet, but hello?
So hi. Yes.
All right, you're back. That was fast.
Yes, I'm back.
Like Superman.
Yes. So this is the last case. It was very nice to see you and very nice to stay with you today and to show you the last case. So we are working with a Pentax unit. This is the J10 series. This is a therapeutic scope, 4.0 millimeters, and we have this case that we do a few days ago. You see here elastography, and the contrast doesn't do any captation, so I decided to do a drainage of the biliary tract, as you can see here, using an axis of a small axis for biliary tract, and waiting for the results. This is a pancreatic adenocarcinoma. So, puedes venir ahora al... So we have, in the Arieta 150, we have the possibility to measure now in kilopascal. So we can do an objective measure, and we already do the measure of this pancreatic mass, as you can see here. So we have in mean, in 10 measures, 32.7 kilopascal regarding the elastography. So this is a very hard tissue, and the histopathology confirm the adenocarcinoma. So the proposal is now to do a radiofrequency before to start chemotherapy in this patient.
Is that something that now you're routinely doing for all patients that are not resectable?
Yes, we are doing a protocol with our institution now. This is the axis here, you see?
Yeah, very nice.
Draining the biliary tract. So we are doing a protocol now because we have saw that in some patients we can rescue and send to surgery because of downstage.
Okay, nice.
So so now I am at the level of the lesion of the pancreas, of the pancreatic lesion, and I will you see, there is something that is under discussion now regarding the putting a standard stent by ERCP or biliary drainage by US. But in this protocol, because we need to do radio frequency, it's much better to have a biliary drainage, because if not, we need to retire the stent.
Okay.
So now I have my needle. You can see there.
Yes, yeah.
I am trying to do a very good, better position. So I am inside of the lesion. And what is the literature saying regarding radio frequency is when we have lesions more than 3 centimeters, as this case, it's better to use more than 30 watts. It means we using mean 40 watts of radio frequency. I will start my radio frequency now. And you can
Perfect.
see the destruction of the tumor is becoming wide. And I always start from the more distal part of the tumor. And then when it becomes wide, I stop and I retire. So
this is great. I've been told that we have only 2 minutes left before they're going to go and conclude. So we can see the ablation because you can see sort of the buzzing nature. What is your protocol on these patients? So you do it. How many times do you bring them back?
So what we will do is the first radio frequency, and then the patients come back to a CT scan 1 month after the first radio frequency. So if we see that the tumor is going down in the size, we continue to do a second radio frequency after 1 month, and then a third one at the waiting 1 month of difference.
Okay. And are you also using it for ablation of mucinocystic neoplasms and pancreatic neuroendocrine tumors as well?
Yeah, the response to this kind of tumors is more than 98% for neuroendocrine tumors and cystic neoplasma also. So this is a very good technique. We don't know exactly what will be happen, but the results are very interesting. At least I believe for the future, for downstaging some kind of lesions and send these patients to surgery as we had already in our center.
Yeah, I really think that this is the way of the future, especially with ablation, because we see it with our IR colleagues. They've been doing it for years, and why shouldn't we start doing it on the pancreas and then other lesions that we see and we can access via EUS?
Yeah, so the idea is not to perform a curative treatment. This is a palliative treatment.
Absolutely.
However, I believe that for downstaging can have a future in adenocarcinoma, in pancreatic adenocarcinoma.
Which I think would be a game changer. I mean, for MCNs and pancreatic neuroendocrine, there's some data showing resolution, but for pancreatic adenocarcinoma, this will be very good, and hopefully it will end up showing prolonging survival in patients that have downstaging of their tumors.
Yeah, that is something that we are evaluating here in a protocol with the oncologist department.
Okay, I've been told now they are going to close. So any final words? Thank you very much. And sorry for getting Ecuador wrong.
It's okay. Thank you so much.
All right. And we're going to go back to Dr. Repici, Dr. Sethi, and Dr. Rösch. And thank you again for having both of us here. We had 2 amazing cases by Dr. Robles.
Who is singing the goodnight song?
So Thomas, I think we need to congratulate Carlos. He did an amazing job, no?
Yes,
Beautiful
very
faces,
calm. He has been
very
waiting for
calm.
us, I think, an hour almost. So we feel
Also
sorry.
for me,
Yes.
for a non-US person, I understood everything. So was very clear. So
Right.
very grateful to Carlos for doing this great job. So what we say is final thing. Do you have any idea? We do not have a plan.
Well, we have a plan. I checked next year. The Friday is June 3, by the way.
Okay, I didn't know this. Thanks
So-
for letting me know.
And I think I find it fascinating. We have seen so many endoscopic cultures, unbelievable. So we were probably the only one watching these 12 and a half hours or 13 hours almost. But I think we both enjoyed it enormously. And we are so grateful to all these centers, you know, getting into the plan and waiting and getting calls and can you please earlier and later. So that was brilliant, especially Carlos, but also others. Pratik jumped in. That was really great. And our teams were fantastic. Rösch was superb. Rösch Media, the transmission company, your technicians, Ale. The sponsors were very supportive. So we are just grateful, aren't we?
Yeah, I do not have too much to add. Rather, than I want to say that at a personal level, there was a very good experience. I learned so much as an endoscopist, as a physician, as a person, multicultural, real, global. So we were tracking the people following endoscopy. And at a certain point, the only area where we could not see a follower was in the Groenlandia, which is probably a too cold place for endoscopy on air. But except Groenlandia, we had a real global coverage from New Zealand to Caribbean islands to Africa, Middle East, and Latin America. So that has been unbelievable. I think it was way much that we expected. So as a last word, we must say this big thank you to all physicians looking to us. We're very grateful to them. We are very keen to keep going with education and training. We are in love with education. This is the reason why we're still here. And of course, as you say, that this can happen without the sponsors, big, small, intermediate, whatever. They are all extremely important to us. They've been also not only generous, but kind. They accepted all the rules of this new toy on the table. So I wait for you tomorrow. You coming to Milano, so we will have a celebration in Milano tomorrow. Please let me know what kind of wine you want to drink, and we're preparing for you. Okay,
I will
good
text
selection.
you. So I hope everybody at home has a good wine, depending where you are. Maybe not in Australia, it's morning, I guess. But thank you, everybody. And thank you, Ale, for this superb cooperation. Bye-bye.
Thank you. Bye-bye, guys. See you next year. Or see you.
Oh, hi, here we are. So artificial intelligence recognizes this. Here we have the cap.
Because artificial intelligence is just seeing what you can see.
Is it open? Yes.
Is very good for using in strictures, this one here.
It's a new type of picture.
They have 4 LED, so you have these brighter, very high quality images.
The advantage of this system is that you can achieve a complete endoscopy in the majority of the case.
With absolutely no risk to the patient.
Yes, we can see it. We can see it very good.
Yeah.
Very good.
Yeah.